So good morning, everybody. So it's a great honor to be here and start the session on lung kidney. And I'm gonna try to build on aspects of particularly lung injury and AKI, which can be distant organ crosstalk victims. I have no conflicts to disclose, and those are my objectives. And I structured my speech into four parts, four points that I think are important when we talk about lung-kidney interaction. So I'm going to start with fluid overload and say a little bit about the heart. And I know that many of the aspects will be covered in the cardinal session, but I would like to emphasize the important role of the heart, as it not only literally connects both organs, but also because the lungs are caught right in this crossfire in this cardinal syndrome. And although by definition acute lung injury is a non-cardiogenic pulmonary edema, I do believe there is a role of the heart, especially of the right heart. Then I'm going to show some findings we have in the field of non-cardiogenic pulmonary edema and its association with the uremic lung, and at last about mechanical ventilation in ARDS. And I don't need to tell the audience the importance of fluid overload, but I will review briefly some of the literature that has been accumulated within the last decade, highlighting what is a really fifth vital sign, and that is cumulative fluid balance in the critically ill patient. And many of the studies were done helpfully by the pediatrics who were the first to show us that we can distinguish between survivors and non-survivors simply by this fluid overload. And it were also the pediatric nephrologists who essentially established a cutoff of not allowing children with AKI to get fluid overload of more than 10% because of the horrible outcomes that are associated with that. And in 2001, Goldstein was one of the first who to assume, is it possible that in some cases CVVH may be a prevention rather than a treatment for worsening degrees of fluid overload, and that early initiation of CVVH would allow sufficient blood product and nutrition administration while preventing fluid overload may improve patient survival. Well, this is a recently published meta-analysis including 7,000 critically ill children, showing that fluid overload is associated with substantial morbidity and mortality, and that includes prolonged mechanical ventilation and in risk for AKI. And that had been followed in adult ICU repetitively in multiple cohorts, showing the same, that we can clearly distinguish between survivors and non-survivors simply by the fluid overload, in a draft that very much mirrors what we see in acute lung injury. In these findings, they challenge the dogma that fluids are good for the kidneys, and we all know that, but they're bad for the lungs. And the concern remains for the lungs, since a liberal fluid administration, so a positive fluid balance, is associated with longer ventilator days and worsening oxygenation, or let me say it differently, that a conservative fluid management, a restrictive fluid management, is associated with less use of ventilator and better oxygenation. And as regards for the kidney, well, these studies, they did not show, despite the dryness that we as nephrologists would suspect, that a conservative fluid management would cause more AKI. Actually, there wasn't more AKI. In fact, there was a trend towards more renal replacement therapy in those patients who were treated in the liberal arm compared to the conservative arm. And following that, many groups looked more carefully into that, including the original ARDS NET trial group itself. And what they did is, first of all, they looked at the fact that fluid overloads dilutes creatinine and masks AKI. And following that, Catherine Liu and her colleagues, they did a post-hoc analysis of the FACT trial and looked at AKI within the first 7 days. And what they found in the first analysis was that AKI is more common in the conservative arm, but when they adjusted for fluid balance, actually AKI was more frequent in the liberal arm. So that shows us we have to use a conservative fluid management, not only because it helps us to reduce the need for the ventilator, but it also may reduce the risk for AKI, to have a conservative fluid management. So as we go on with the heart, you all are familiar that there is a Cardinal Syndrome and there is an interaction between chronic kidney disease cardiac disease and adverse cardiovascular outcome. I think it has been less well recognized that there is an acute renocardiac syndrome and there is an inflammatory injury that occurs from kidney injury and results in cardiac dysfunction. And we all know that systolic diastolic dysfunction, ventricular arrhythmia, they are much more frequent in the setting of AKI, which can impair the cardiopulmonary circuit and lead to pulmonary congestion. So although by definition, acute lung injury is a non-cardiogenic pulmonary edema, I do believe there is a role of the heart, but especially of the right heart, as nowadays we have a growing body of work in the heart failure literature suggesting that that the fluid overload is not only a problem in terms of respiratory failure and pulmonary congestion, it's also a problem actually in terms of worsening cardiac function, particularly in patients with right ventricular dysfunction. Pulmonary hypertension is frequent in patients with acute lung injury. It occurs about 40% on those patients. Many of those develop right heart failure and venous congestion. And nowadays we know that venous congestion, rather than cardiac output, is the main hemodynamic driver for worsening renal function. And the basis for that was set more than 50 years ago, showing that an increased venous pressure is likely to decrease the renal blood flow by increasing the interstitial pressure within the encapsulated kidney, some kind of a renal compartment syndrome. And there are in fact similarities to obstructive nephropathy and intra-abdominal hypertension, which also increase the intra-abdominal the pressure within the kidney. And that can worsen renal function and lead to a spiral with fluid overload, diuretic resistance, pulmonary congestion, right heart failure, which is really difficult to get out of without actually removing fluids. So as we go on to the non-cardiogenic pulmonary edema and its association with the uremic lung. Now this has been recognized for a very long time. Actually it was described back then in 1950 that in acute kidney injury there is a different finding of lung injury happening in patients with uremia. And the uremic lung, it's characterized traditionally by its butterfly appearance in the chest x-ray, and actually it's not fluid overload. It's more the patients, normally when they come to the emergency medicine, they're quite dry. It's more a phenomenon of a protein-rich edema and capillary leak, and that is associated with pleuritis and pericarditis. And back then, Barth and colleagues, they associated it with left ventricular failure and kidney dysfunction, but nowadays we know it's a direct interaction between the lung and the kidney. And the basis for that has only been set more than 50 years later, and much of the work was done by Hamid Rob and his group, showing that it's not only renal ischemia reperfusion injury that can induce acute lung injury, but it's also removal of kidney that can acutely induce acute lung injury. So it's not just a phenomenon of a renal ischemia reperfusion injury associated with oxidative stress or whatever. It's also decrease of renal function acutely that can induce acute lung injury. And following that, many groups looked at different mediators of remote lung injury following AKI, and among those, serum interleukin 6 is probably the best described pro-inflammatory mediator of remote lung injury after AKI, with good evidence from experimental studies and human studies. And it has been shown that interleukin 6, actually it was done in the original ARDS-NET trial, that it predicts prolonged mechanical ventilation in patients with AKI with a ROC curve of more than 0.9. And nowadays we have an increasing body of work about the development of uremic lung at the cellular level, which I think is really fascinating. So in the physiological state, the epithelial sodium channel, INAC, is responsible to get the water out of the alveolus. And the water clearance is done by aquaporin 5. But in the setting of AKI, we have a downregulation of INAC and aquaporin 5, which leads to an impaired resolution of pulmonary edema, and also we have an activation of the NKCC1, which leads to active flux of water into the alveolus, at least in experimental models. And this is, for me, probably the most striking interaction that we have between the lung and the kidney. When you look at the carrier, they're the same we have in the kidney. So by giving the diuretic amyloid, we can induce pulmonary edema, at least in experimental models, because it blocks INAC. And by giving furosemide, we can prevent pulmonary edema as it blocks NKCC1. And that is probably, at least in my opinion, one of the reasons for the rapid and diuresis-independent action of furosemide that we see in patients with pulmonary edema, independent of its vasodilative properties. Well, and this slide summarizes the spectrum of lung edema that we see in patients with AKI. So on the left side, you see the cardiogenic pulmonary edema, which is a result of fluid overload and or cardiac dysfunction, leading to a transudative pulmonary edema. In those patients, they improve very fast when we remove fluids. On the other hand, we have the non-cardiogenic pulmonary edema, leading to a capillary leak and protein-rich edema. And those patients, they improve little or not at all if we remove fluids. The problem is that many of our patients, they fall in the spectrum between those both, cardiac and non-cardiogenic pulmonary edema. So the concept of being emptier is probably better than being overfilled, as it not only helps us against the hydrostatic edema, but also it reduces filling pressures and reduces the edemagenesis in those patients with acute lung injury, because obviously those will develop pulmonary edema at lower filling pressures compared to those patients who have an intact barrier. And following AKI, there are traditional complications that have been recognized for more than 50 years, and they would include fluid overload, electrolyte, acid-base disorders, and so on. And those are typically corrected with renal replacement therapy. And more we're realizing that we have non-traditional complications like upregulation of mediators of distant organ injury that have been studied in the past 2 decades and which require therapy beyond renal replacement therapy. And I think, at least it's my belief, that it is these non-traditional complications that are responsible for the high mortality in those patients. And we're more and more realizing that acute lung injury and capillary leak is a phenomenon that can be induced by AKI. I would like to make a short comment that nowadays we recognize AKI is associated with a huge problem of coincident sepsis, which affects its outcome, and that there is an increased risk or susceptibility for pneumonia, which directly reflects risk of acute lung injury, and that AKI leads to an immunocompromised patient, and we all know that, which then impairs the response to these insults. And of course, that's a problem of a whole nother talk, but I think it's something we should think about. So now to the last point, mechanical ventilation in ARDS. So regarding all the information that are delivered, on the one hand, we have the stiff, non-compliant lung, edema lung, and the fragile kidney, and now we put mechanical ventilation on top of it. So what can happen? Well, there are different mechanisms that have been described in the literature that can adversely affect renal function during acute lung injury, mechanical ventilation, and those include blood gas disturbances, hemodynamic and neurohormonal alterations, and systemic release of mediators. And the big question is always, how do we manage patients with coincident respiratory and renal failure, because we know it's quite common and the outcomes are quite bad. So the original trial of the ARDS NET group, which resulted in the lower mortality in this syndrome, was the high tidal volume compared to the low tidal volume. And in this study, it was recognized that patients ventilated with low tidal volumes compared to high tidal volumes, they have an improved survival and improved ventilator-free survival because we have less injury to the lungs. And actually what it showed us is that not harming the already injured lungs with more tidal volumes is the mechanism of benefit. So we all know that mechanical ventilation is a life-saving procedure, no doubt, but it may have adverse effects that we should think about. And there are multiple ways of thinking how the ventilator may have an impact on the kidney. First of all, there is the simple mechanical aspect of positive pressure ventilation, that it increases the intrathoracic pressure and produces adverse effects that are opposite to normal spontaneous ventilation. And positive pressure ventilation can compress the pulmonary vasculature depending on the fluid status, depending on the pressure, and that can lead to low cardiac output, pulmonary hypertension, right heart failure, and venous congestion. And increases in positive pressure ventilation PEEP are associated with less reduced renal function, and that is in contrast to non-invasive ventilation, which may better preserve renal function. And there are secondary effects of the ventilator on the neurohormonal system that include activation of sympathetic nervous system, renin-angiotensin system, and release of antidiuretic hormone. And there are several studies showing that hypercapnia and hypoxemia, they compromise the renal blood flow and GFR in a dose-dependent manner, and they act synergistically. And during hypercapnia, we have a loss of renal vasodilatory response to various stimuli, and that includes protein loading, which may then affect the renal outcome, including duration of AKI and renal recovery. And this is in contrast to permissive hypercapnia, which appears to be beneficial in reducing lung and kidney inflammation. However, this is controversial, I have to say that. And there are secondary effects of the ventilator in terms of inflammation, which causes what has been termed as the ventilator-induced kidney injury. And what we learned from the original ADS-NET trial and several other trials is that in those patients who are ventilated with low tidal volumes, we have less injury to the lungs, we have less inflammation, and we have less organ failure, including less AKI. So one of the reasons why we as nephrologists should be aware of that is that managing the ventilator properly leads to less secondary injury to the kidney and other organs, because we want to avoid a vicious cycle of acute lung injury caused by AKI, leading to maladaptive ventilation, resulting in worsening kidney failure. And Catherine Liu, amongst others, they actually have shown that there is more systemic inflammation in those patients who are ventilated with lung injurious ventilation compared to lung protective ventilation, and that during lung injurious ventilation, pro-inflammatory mediators, they can probably translocate into systemic circulation and cause then distant organ damage, and that is actually associated with more AKI. The story has been very well told. It means we have to use lung protective ventilation not just to protect the lungs, but also protect the kidneys. So when we go back to the start, we know we should avoid cumulative fluid balance, because not only to reduce the hydrostatic edema risk, but also reduce the edema genesis in those patients with acute lung injury because of the damaged barrier. So the concept of being empty is probably better than overfilled. Right ventricular dysfunction and venous congestion can contribute to impaired renal function. AKI leads to pulmonary edema by both high pressure and low pressure mechanisms, and AKI is associated with lung injury and downregulation of lung and water cells, which is probably the correlate for uremic lung. And during lung injurious ventilations, there are different mechanisms that have been described that can cause distant organ injury, and among those, pro-inflammatory mediators that can translocate into systemic circulation. So, yes, I think we have to think more broadly. Reducing mortality in AKI will require more than just managing fluid potassium, anemia, and so on. So those would be the traditional complications. And nowadays, we realize that there are non-traditional complications that are probably the reason for the high mortality in those patients. And for that, we have to think beyond renal replacement therapy. Thanks.